Hello and welcome everyone. My name is Matt Shepard and I'll be your moderator for today's Team Gleason Center for Medicare Advocacy Town Hall. This session is brought to you as part of the joint Team Gleason Center for Medicare Advocacy Medicare and Home Health Initiative to help people living with ALS understand Medicare, including the home health benefit, and to maximize access to coverage and care. The Center for Medicare Advocacy, as some of our audience probably know, is a nonpartisan, nonprofit organization which, since its founding in 1986, has worked to obtain fair access to Medicare and quality health care for older people and people with disabilities through education, training, analytical research, advocacy, and legal assistance. The center is staffed by attorneys, advocates, nurses, and technical experts, all working for systemic change based on our daily experiences with the problems of real Medicare beneficiaries. Team Gleason's mission is to help provide individuals with neuromuscular diseases or injuries with leading-edge technology, equipment, and services to create a global conversation about ALS to ultimately find solutions and an end to the disease, and to raise public awareness toward ALS by providing and documenting extraordinary life adventures for individuals with muscular diseases or injuries. The Team Gleason CMA Medicare and Home Health Initiative includes 3 webinars, all of which are available for viewing online at medicareadvocacy.org/webinars, and they are chock full of information from coverage basics to case studies. So if you haven't seen those, please go check them out. They will answer a lot of questions. The initiative also includes a dedicated email portal for those living with ALS to ask questions and share their home health access stories. You can share yours at homehealth@medicareadvocacy.org. And of course, we have one more town hall session scheduled for the second Wednesday of August. And you can register for that now, right below the Gleason webinars on our webinar page, which again is www.medicareadvocacy.org/webinars. Once again, we are grateful to Team Gleason for their support of this important initiative, and we just found out that we all have an opportunity to show them how much we appreciate that support. We just learned that Steve Gleason's been nominated for our country's highest civilian honor, the Congressional Gold Medal. And it's passed the Senate unanimously, but they need more House co-sponsors. So please, we encourage everybody online today, go to honorgleason.com once we're done here today and send a message to your representatives to support Steve. Our experts for today's presentation are Center for Medicare Advocacy Director Judith Stein and Associate Director Kathleen Holt. Before I let them start, however, I need to do my usual presentation housekeeping. If you can hear me, you've used the information in the email you received after registering to successfully log into our webinar, and you've either dialed in by phone or you've got good quality working speakers on your computer, either of which is great. If you use the phone call in, we'll be able to hear you when we open up for questions. Otherwise, please do be sure that your computer or device has a good quality microphone. If you aren't, it's never too late to dial in using the instructions provided on your confirmation email or under the audio tab on the control panel at the right of your screen. If, as occasionally happens, you dialed into the audio without actually logging into that online portion, you'll be able to hear us, but you won't see that control panel or today's presentation. And yes, this session's a little bit different than our last one because we do have a presentation, because we have some interesting news to share, and not just us. We also have a guest speaker with something worth hearing to start us off. And of course, we will tackle questions with our remaining time. And on that note, I want to thank the several people who submitted questions when they registered. One more thing on that control panel I mentioned. Please note particularly the little picture of a hand at the left side. That's used to indicate that you have something to say. As always, we have quite a few registrants, so for the bulk of the presentation, we're going to keep folks muted. But you can click on that hand icon to let me know you want to jump in, and I'll unmute you. Of course, if you're shy or you prefer not to try the audio, our control panel, as always, has a questions section for you to use. You can just type what you want to say in there, and I will relay it to the best of my abilities. Thank you all again for attending today. And now, before we hand things over to Kathy, I would like to welcome Jeff, who has agreed to share a recent story with us. Jeff, are you there?
Yes, I'm here. Thank you.
Excellent.
My name is Jeff. My wife Susan has ALS and has been diagnosed for a little over a year. We've been dealing with home health for a while. I stumbled across the webinar online, and what I did was basically I viewed them all and did screenshots of each slide that I thought was pertinent to our current situation. After doing that, I went and looked up the laws that were cited, printed those out, and contacted both our general doctor and our neurologist and told them kind of our situation and what we were looking for, which was more custodial type care for her at home as a home health aide, as I still work full time. And what happened was pretty good. What we did is I met with the home health team. I brought those slides with me, explained our entire situation to them. I had the laws right there that were cited, printed out. I'd looked those up on Google. Brought all that information to me. I felt like I was really prepared thanks to the information on the slides and from the webinar, and it went really well. And starting this Monday, we have home health in our home 28 hours a week, which is really taking a lot of the pressure and stress off of me, and has been a very, very good addition to our treatment plan. So just wanted to share that with everyone, that this worked well for us, and I really appreciate it.
Thank you very much. It's really heartening to know that it really can be done. It gave me chills to hear it. Kathy?
Great. Thank you so much, Jeff. And I'd also like to share another story that we received from Jean in Massachusetts. And Jean was able, through, again, a similar to process to what Jeff used, but to help an individual who was getting care through a home health agency to prevent a discharge from that home health agency. By using the materials to confirm that Medicare equally covers skilled services to improve, maintain, or to slow deterioration of function. And the home health agency that she was working with, that again is going to continue the care, stated that it would help other similarly challenged families. And the home health agency, which is Partners Home Health, a Harvard affiliate, is anxious to spread the word as well. So to make other home health agencies aware and to be able to follow the laws as we've described them. So good. We love to hear these stories of success and challenges, everything that we can do to forward the purpose that we're all about here. So today we're going to do something a little bit different. We, of course, had planned a town hall to answer questions and address some issues that have come up, but we were made aware last week of the new proposed home health rules that are coming out, actually to be published in the Federal Register tomorrow, July 12th. And in it is a Medicare home health clinical example that's described by CMS. So for our agenda today, we just want to do a very quick overview. As Matt mentioned, we have all of the very detailed presentations that we've done before, so we don't want to spend much time on coverage. We have 2 slides, a high-level overview of what home health care is. And again, we've recorded the previous coverage, the detailed Team Gleason presentations, and they're available on our website. Part 2, again, we're going to describe the clinical example. So you were sent 3 attachments if you registered for today's town hall, and included in this is the slide presentation we're watching. The second attachment was a published article about people who are having trouble accessing Medicare home health services, highlighted a patient with ALS. And this article was referenced in the 3rd attachment, which is the CMS clinical example of how someone with ALS can get coverage. And again, this will be published tomorrow in the Federal Register. But Judy and I will briefly go through that clinical example. Judy will discuss the CMS coverage, which is an affirmation that what we've been telling you is true about how much care you can get. And then I'll discuss the payment part of the example, which is an affirmation to home health care agencies that they can get paid a significant amount to provide care to someone who has significant care needs. And then we'll take questions and have a discussion and a call for advocacy about our next steps. So I'll turn the program over to Judy.
Thank you, Kathy. And as Kathy indicated, I'm going to give a brief overview of the Medicare home health coverage rules so that we are on the same page for those of you who haven't been on our webinars before or who just may have forgotten a little bit of it. It confirms what Jeff and Jean wrote to us, that if you follow these, if you know this basic criteria and provide the information to the home health provider, hopefully you will be able to get these services in place if the doctor feels they're necessary. So first of all, the doctor, be that the patient's primary care physician or neurologist, a doctor must have written a plan of care, certified that it includes necessary and reasonable services, and had a face-to-face presentation meeting with the patient. Actually, that face-to-face can be done with an advanced practice nurse or a physician's assistant, but the doctor must sign off on the plan of care, as well as attest to the fact that there was an in-person meeting known as a face-to-face meeting with the patient. Number two, the person, in order to get Medicare home care coverage, must be homebound. As we always say, this does not mean bedbound. It doesn't mean the person can never leave home. What it does mean, as you see here, is the person has an inability to leave without a device or assistance, or both, or leaving home is contraindicated, for instance, because they have a mental health issue or cognitive disorder, and they just need assistance in order to be safe outside the home, and that it requires a considerable and taxing effort to leave home. Again, not that you can never leave home or that you have to be bedbound. And then if the doctor has had the face-to-face and has certified a plan of care, and the person meets the legal definition of homebound, the care must include reasonable and necessary skilled services. And for this purpose, that means nursing, physical therapy, or speech-language pathology in order to qualify for Medicare coverage of home care. And here we have, and as Jeff indicated, these citations are very important because they'll get you to the law to show that what we're telling you is what you should be able to count on and the home health agencies should follow. Now, if those things are met that I just described, and the person needs a skilled service, nursing, physical therapy, or speech-language pathology, then dependent on those things being in place, the individual can also receive one other skilled service called occupational therapy. And if the occupational therapy is in place and one of the other skilled services is discontinued, that will still be sufficient to continue home health care. And dependent upon one of those skilled services being in place, an individual can get coverage for those critically important home health aid services that Jeff referred to, medical social services, and certain medical supplies if you are receiving skilled services. So those two slides give you the basic coverage criteria for Medicare home health coverage. And just let me reiterate that the home health aides and nursing combined can be up to 28 hours or with special documentation, 35 hours per week. So Kathy discussed the fact that just last week we learned that there are going to be new home health payment rules, which may present some problems, but there is some good news. And the good news is that in those proposed payment rules, we will find, because we sort of got a sneak preview last week, they'll be formally issued tomorrow, a clinical example which actually is based on an ALS diagnosis. In the clinical example, which is described and published by CMS, or will be formally published tomorrow, CMS, the Centers for Medicare and Medicaid Services, which is the federal entity that runs the Medicare program, acknowledges what we all know, and that is that there has been difficulty for people accessing coverable home health care, receiving the care and receiving Medicare coverage, especially when the patient's individual condition is not expected to improve. And CMS also acknowledges confusion among home health providers regarding possible payment for this care. Although they'll be published tomorrow in the federal, what's called the Federal Register, and generally these rules are pretty high level, big picture images of what's changing. The proposed rule that CMS is going to issue tomorrow includes a specific example of how care for a patient with ALS could qualify for coverage, and how the home health agency could receive additional outlier payments for providing that care. And by outlier payment, what we mean by that is more payment for providing more services than CMS thinks most home health patients need and receive. Most importantly is this quote on page 10 of what was published, 110 of what was published last week. And the quote is, "We hope that in providing the example, which illustrates how home health agencies could be paid by Medicare for providing care to patients with higher resource use in their homes, and by reiterating that the patient's condition does not need to improve for home health services to be covered by Medicare, that there will be a better understanding of Medicare coverage policies and how those outlier payments I just described can promote access to home health services for such patients." So again, you know, this of course warms our heart here at the Center for Medicare Advocacy every time we hear CMS recognizing, as they should, that a patient does not have to improve in order to receive Medicare coverage, and in this setting, particularly for home health care. In that same clinical example, CMS acknowledges that because of the progressive nature of ALS, care needs change, and more importantly, perhaps, recognizes that the needs intensify, don't diminish, as different body systems, unfortunately, are affected by ALS. So that's terribly important, because sometimes, regrettably, you may hear home health agencies say, we can't stay in place, we can't continue providing this care, because not only aren't you improving, but you are you need more services because your condition is diminishing. CMS recognizes that that's not a reason for denial, and that care could continue and should meet the increased intensification of need. Clinical care typically includes ongoing assessment of and treatment for many impacts to the body systems of ALS. And again, CMS recognizes that in the statement that was issued last week. Another part of the example is how the episode, the 60-day or soon 30-day period of time, what might be included in terms of the care during that period of time, what the doctor might have ordered, what might be in place for a particular hypothetical ALS patient. That could include, CMS recognizes, a skilled nurse to assess the patient for shortness of breath, and these other incredibly important components of having ALS. The key is that the skilled nurse is observing and assessing and consulting with the doctor about changing to the care plan. The home health aide is also a key component of care, CMS recognizes, and they haven't been recognizing this. So this is very important. And also, as we put here in parentheses, please note that CMS referred to the home health aides in some places in this statement last week as a nurse's aide. But we want to continue using the word home health aide because that's the name of these services in the regulation and in the Medicare law. And we don't want to have any inference that there has to be a nurse in place in order to get home health aides. You could be receiving therapy and no nursing and still be entitled to a home health aide. So the doctor should order home health aide as are required. And those services that the federal regulations and statute require allow the home health aide to provide and be covered under Medicare for include assistance with bathing, grooming, dressing, toileting, transferring, all these other kinds of direct hands-on personal care. Incident to that may be some homemaker services, but what home health aides need to be doing and documenting is hands-on personal care. And then physical therapists, CMS also recognizes as part of what a patient might be receiving during this treatment plan, to provide range of motion exercises, for example, or adaptive transfer techniques, and assist as the person's functioning changes. And this could be to try to maintain a level of function or slow decline, not just to improve. In addition, the ALS Clinical Example describes by CMS includes an example of what a doctor's order might look like. And what I wanted to point out here is that the hypothetical, the example doctor's order shows the type of service. So here the first bullet is the skilled nursing. How often does the doctor think it needs to be done? 2 times a week. For how long? About 45 minutes for each of those visits. And why? To assess dyspnea when transferring to a bedside commode, stage 2 pressure ulcer at the sacrum, and pain status. So for each of these services, the doctor is saying what the service is, how often and how long it should be provided, and for what purpose. So again, here we see the same thing for the home health aide. The doctor says in this example, 3 hours in the morning, 3 hours in the afternoon on Monday, Wednesday, and Friday, each for 2.5 hours, and on Thursday and Tuesday and Thursday to also assist with bathing, dressing, and transferring. So you can see, again, what is the service, how often, when, and for what purpose. Physical therapy, 2 times a week, 45 minutes for each visit for adaptive transfer techniques. And this hypothetical patient also has an order for occupational therapy 2 times a week for the assessing and teaching of the use of assistive devices for the activities of daily living. That's what ADL is. Why? To prevent or slow deterioration of the patient's condition. I think this is a very helpful slide for you to keep and note if you're speaking to the doctor who you are talking about getting an order for home health care, because this is the kind of order that will provide sufficient detail to be recognized by Medicare for coverage, or at least it should be. And with that, I'll turn it over to Kathy for the next component of what we learned last week from CMS.
Great, thank you, Judy. Yeah, so again, I'm going to address the payment part of this from the standpoint of helping the home health agency to be open and receptive to offering services. So the example in the proposed rules goes on to describe in great detail how an agency would be paid to provide the care, which of course will make the agency want to provide the care. You shouldn't have to understand this, but sometimes the agencies don't know about it or they don't understand it. So it's best to understand how it works. The ALS Clinical Example assumes the home health agency will be paid for services, as Judy mentioned, via a high-cost outlier. So high-cost outliers use a cost per unit approach in 15-minute increments, rather than a cost per visit approach. So rather than one flat amount per visit, payment amount per visit, depending on if a person is there for 15 minutes or 3 hours, for example, the high cost outlier allows for 15-minute payment increments. So for instance, we know that it takes a long time to help someone with ALS to groom and get ready for the day and to get dressed. And so this idea of using this high cost per unit approach will more accurately pay the providers for the services that they're delivering. And it becomes more important for people who have an unusual amount of care. There's a limit of 8 hours of care per day, or 32 units, again, remembering 15-minute increments for outlier payments. And a home health agency will be paid the standardized 60-day bundled payment that is usually paid in a home health case, plus they will receive an outlier payment. So let's look at the specifics in the ALS clinical example. For the first 2 episodes of care, and just to remind everyone, 60 days is considered an episode. So essentially every 2 months is an episode. The clinical example assumes the patient is in a standard payment group with 20 plus therapy visits. That's the kind of the top level of a standard group, is someone who is getting more than 20 therapy visits over that 60-day time period. And it could be a combination of speech language pathology. It could be occupational therapy, physical therapy. So any of the therapy disciplines would be included in that 20 number count. So it also assumes the patient lives in a Los Angeles wage area for purposes of the wage adjustment of this payment example. I have to say, if Colin Campbell is on the line, that this is an example that was really based on an article that was written about Colin and his challenges in trying to get home health care. So in using the example, the CMS went to the Los Angeles wage region. A standard 60-day episode payment would be almost $8,000. So that's what that would be the flat amount that the home health agency would typically get. But in this case, with an outlier payment added, so in addition to the $8,000, the home health agency would get an outlier payment based on the formula that considers all of those units of care that Judy outlined for each one of the different disciplines. And that would result in an additional payment of over $12,000. So the total payment to the home health agency for an episode, a 60-day episode, would be over $20,000. So the reality is, we know a home health agency will be more interested in serving people with ALS with significant care needs if they can get paid $20,000 every 60 days rather than $8,000. Then the example goes on to describe care after the first 2 episodes. So after the first 4 months of care, the example provides what would the payment be after for the next 4 months. So essentially, this example is looking over approximately 8 months worth of care. But in order to kind of bring it into the payment discussion, CMS describes what would kind of have to be happening, or what they understand is happening in the life of someone with ALS for those later episodes of care. So CMS states that ALS is a progressive disease such that the patient would most likely need care beyond a second 60-day episode. A beneficiary's condition could be more complex, as an example, such that the patient could require a gastrostomy tube placed during a hospital stay. Again, this is CMS's example. The patient could be discharged home for enteral nutrition to maintain weight and continuing care for his or her stage 2 pressure ulcer. These are just examples of the kind of clinical reasons that someone would meet that necessary standard for Medicare coverage. Given the complexity of the patient's condition, the episode would remain at the highest level of care. There's 20 plus therapy visits per 60-day episode. These are the assumptions that they're making in order, again, to reach their payment criteria. So in the CMS example, care needs and delivery disciplines remain unchanged, the same amount of skilled nursing, physical therapy, occupational therapy, and home health aides as the first 2 episodes. So payment for the 3rd and 4th episodes of care as described by CMS, again, assuming the patient remains in the payment group, which they've already described that they do, and assume the patient living in the Los Angeles region, would result in a slight payment increase as it relates to the first 2 episodes. So essentially, shifting just slightly because of a ratio calculation, but the home health agency would continue to get paid more than $20,000 for each episode, as they did in the first 2 episodes. Also, please remember that there is no cap on the amount of days or years someone can get home care as long as they continue to meet the medical qualifications. So as we know, with ALS, it's important to provide care for the lifetime of the individual, and Medicare should be there to provide that benefit for people. So this is just the conclusion, and I thought it was really important that we lay this out. This is the conclusion by CMS. For episodes 3 and 4 of this clinical scenario, the above calculation demonstrates how outlier payments could be made for patients with chronic complex conditions under the home health prospective payment system. That's the bundled payment system that's used by Medicare. We reiterate that outlier payments could provide payment to home health agencies for those patients with higher resource use, and that the patient's condition does not need to improve for home health services to be covered by Medicare. We appreciate the feedback we have received from the public on the outlier policy under the prospective payment system and look forward to ongoing collaboration with stakeholders on any further refinements that may be warranted. We note that this example is presented for illustrative purposes only and is not intended to suggest that all diagnoses of ALS should receive the grouping assignment or number of episodes described here. The CMS grouper assigns these groups based on information in the OASIS. And again, the OASIS is the assessment tool used by home health agencies. So we thought this was really important to share this example with our group. We want to now move forward into discussions and look at questions that you may have about this, a call for advocacy and next steps. And of course, as we preempted our usual town hall questions, we would be happy to answer any questions about Medicare coverage after we discuss this. We also want to talk about our call for advocacy and next steps, and how we hope that you will continue to be interested and to help us to help others as we move forward with really trying to make changes. I have to give a shout out to my friend Catherine Scott, who was so excited about this information we put out there that she interpreted it to mean that an expansion of Medicare benefits was happening. I have to say at this point, we are working so hard to make sure that the Medicare benefits that people should be legally receiving are accomplished, and then our next fight will take us into the expansion realm. But we work together as a team, and we cannot do this work without folks like Jeff and Jean and everyone who gives us more information about what's happening, whether or not it's working. If it is working, that's great. We recently had a call with our advisory board, and Senator Chris Dodd said to us, you know, sometimes we hear so many bad stories. Sometimes what is the best thing we can do is tell the success stories, because it's the success stories that will help people know that they can get the benefits that they should be getting, and also help the home health agencies know that we're expecting them to deliver the services that Medicare covers. So given that, I'm gonna move us to a live version and off of the slide so that Judy and I can talk to you and answer questions, and Matt can facilitate that part for us. So a little patience, because my technical abilities are a little challenged. So
They're excellent.
okay.
There we go.
Okay. Perfect.
That was pretty smooth.
Hopefully
That went pretty well, I think.
That up there.
Here we go.
Okay. It's Judy and me.
Yeah, thank you, Kathy. I think it's so wonderful to see that CMS is actually very clearly recognizing and listening to what we've been saying about improvement not being necessary, and showing home health agencies a way to use the payment system to meet the needs of people who have ongoing need for home health care. So So let's answer some questions.
Okay.
All right. Thank you guys for that presentation. That was great information. We've gotten some comments to that effect. I think this is something that people did not necessarily know about, and it's going to be very helpful. We have a couple questions on some of the content from today. One is sort of a standard question that we get on this stuff. Kathy asks, how would these rules you've just discussed apply for someone in a Medicare Advantage plan?
Yes, we do get that question a lot. And the answer is legally, under the law, the Medicare Advantage plan must provide the exact same coverage, at least, as we just described. So everything we just said does apply to people receiving their Medicare through a Medicare Advantage plan.
Right. You'll notice the only thing that should be any different would be that there are a number of Medicare Advantage plans that do charge a copay for home health care benefits, some as much as up to 50%. Whereas under traditional Medicare, there is no co-insurance amount for home health benefits.
Right. So the coverage, the benefit should be at least as strong. You might have to pay a copay if you're in Medicare Advantage.
Thank you very much. This is a payment-specific question from David, who's wondering, did you say that the standard payment would go up in the 3rd and 4th episodes? And if so, do you know why?
Yeah, just slightly. There's all kinds of things. And if anybody really wants to know about fixed dollar loss ratios and all kinds of statistical calculations about how they come up with the payments, I'm happy to have that conversation. But essentially, they add things and they take things out. And for our purposes, and I think probably for the home health agency purposes, that we were always, frankly, under the impression, not being payment experts, that the payments went down after the first 2 episodes. But again, on high levels of care, such as this illustration points out, there is no drop in payment. Essentially, it's negligible. Of a $20,000 payment, it's less than $100 of change from the first 2 episodes to subsequent episodes.
So let's hope it's because they're trying to provide an incentive to keep patients who continue to need the care longer than what is presumed to be the norm.
Great.
Thank you very much. Question from Juliet. Hi, Juliet. Can we just make it clear that these new payment policies that you've discussed apply to any diagnosis, not just ALS?
Oh, absolutely.
Yes.
Right. That should be, yeah, it doesn't matter what the diagnosis is. It really has to do with the care needs of the individual. So just as we say there are no rules of thumb in Medicare, there's no rules of thumb for particular diagnoses. So whether the person has
MS, Parkinson's,
Exactly.
ALS, a stroke, paralysis from an injury, everything we said should apply equally.
Right.
And thank you for pointing that out.
Right.
Thank you. Good question. We have a question now related to Jeff's story, actually. Libby says, I followed the same procedure as he stated, took the info to a clinic, the doctor made an order, sent the order to the home health agency. They did put her husband on Medicare maintenance plan to continue bathing and his nurse coverage. When she suggested the 28 hours, they said, we don't have the staff for that. How can we address that issue and get them to follow through?
That's a tricky question, tricky situation, and we're hearing it more and more. I think that the more patients need and push for home health aides for more than just a few baths a week, the more that CMS does things like we've just seen, where they actually make it clear that you can be paid home health agency for providing that service, that perhaps the home health agencies will staff up properly again, as they had. But at the moment, I think it can be a combination of an agency not wanting to take on people who need that level of home health aides, and also some legitimately not having the home health aides that they need to meet those needs. And as we've seen in prior webinars, regrettably, the conditions of participation in Medicare, the contracts the agencies have with Medicare, don't require them to have any specific amount of any particular one of these services. So you might be able to get the agency to shop around, to get the agency to make an arrangement with another entity to provide the home health aides. They won't be terribly desiring to do that because then they have to share the Medicare payment, but that is a possibility. Or again, look at another agency to see if you can find one that has the staffing. Do you have any other suggestions?
Yeah, no, I would suggest if you look on the Medicare.gov website and the Home Health Compare tool, you put your zip code in and it will tell you what Medicare certified home health agencies will serve your zip code. And kind of, it's a little bit hit or miss, but go down the list, make calls and see if there's another agency who does have the appropriate amount of home health staffing. That's an example. And again, would ask anybody, please, if you happen to go through that exercise, to let us know, because what we want to do is we want to be able to say to CMS that somebody in this zip code had 10 agencies to call and called them all and couldn't get the services that Medicare covers. So we want to make sure that that disconnect gets connected.
And be sure that you tell them now this information we've given you today, that there is a way to get additional payment if the agency goes ahead and provides the additional services.
Right. And again, the payment part of it is a little convoluted. You can look at the example that we sent. But essentially what it's saying is that a home health agency will get reimbursed up to $15 for a unit, which is again 15 minutes for a home health aide. So while that again gets a little bit convoluted in the example, they certainly are not losing money by staffing with home health aides. We're going to be putting out some more information that will talk about home health aides are more likely to stay with an agency if they're trained properly. So again, finding an agency who invests in their staff can go a long way toward making sure that you can get home health aid services.
Thank you for that. Sudharani asks, does PT and OT and the home health aide need to be provided by the same agency?
Yes. So under Medicare, and Judy talked about making arrangements, that the reality of the way that the Medicare policy manual is written is the arrangements can be made typically with an institution for care that cannot be provided in the home. So such as a rehab facility that may have specialized equipment or specialized staff. Those kinds of arrangements can be made, but typically a home health agency is in charge of the payment. One home health agency is assigned to one person's care and they get the entire payment, and it's up to them to determine how that payment gets split up, if you will, between the different disciplines. And I would think it would be very difficult for an agency to not want to keep all that money for themselves. I'm not articulating that very well.
Yeah, is it true that they can make arrangements with another Medicare certified home health agency to provide a service they don't have the staffing for, but they won't be inclined to do so because then they have to share the Medicare payment. Is that correct? If it's not, say.
Yeah, no, I interpret this is how we work.
Yeah.
I interpret the policy manual to say that the arrangements should only be with an institution where a person can't get care. We can clarify this and we'll put it out we have a list of frequently answered questions. So on the make arrangements question, we will definitely clarify that for everybody.
Good, thank you.
Thank you. Abram asks, there's a little recap here of what we've been discussing. It's important that CMS is bringing attention to this problem, which reflects the systemic underpayment of home health agencies for services provided to persons with ALS. Under the PPS, CMS explicitly recognized in the proposed rule that home health providers suffering such underpayments could only hope to reduce but not eliminate underpayment for treating patients with ALS by the use of the outlier adjustment to the HHPPS system. Almost there. Sadly, even in the carefully crafted and complex illustrative case provided by CMS, the providers underpaid by thousands of dollars, loss of 20% of imputed cost of care per 68-day episode. How do you think this rule will impact patient avoidance by home health agencies?
So what he's this the 80% is the loss sharing ratio that is over and above what the imputed costs are. So it's a little tricky because there's a lot of studies that show that home health agency costs, reported costs, are overinflated. And that's a whole other policy issue. But I would say that, again, when we're talking about a comparative type of an example, when you're talking about paying a home health agency $20,000 for services, they're in especially the services that we've described in this example, there are enough home health agencies that are efficient enough to make the payment. And since we're on the topic, I will also just mention that the MedPAC, which is the Medicare Payment Advisory Commission, has said that year over year, statistically, home health agencies make between 16 and 20% profit on Medicare cases, traditional Medicare cases. And when we talk to our friends at the National Association of Home Care and Hospice, they will tell us that the typical margin for a home health agency is between 3 and 4%. Well, why is that? Well, part of that is that they don't get as high payments from Medicare Advantage plans and from other insurance such as Medicaid, although private insurance does pay higher. So there's all this kind of balancing that's happening, and that's my long way of saying I think that this is sufficient reimbursement through these outliers payments for an efficient agency to be able to serve, particularly if they have a mission to serve patients who have chronic long-term conditions.
Thank you very much. That was no easy question. Jeff has a follow-up, actually. Not to that question. Where would we be able to view the CMS statement in its entirety when it is released?
So we'll put that out tomorrow. Once we see it, we'll send it to everybody who registered for the webinar.
Perfect.
Yeah, and we and to that point, we are going to be scouring it. What we gave you was part of a 600-page document. When it's published in its final form, it'll probably be closer to 300 pages. It's a lot of detail. It's a lot of information. We will analyze it, read it, analyze it, spend a lot of time with it, and then we will write our comments. And what we'd like to do is share our comments with everyone ahead of time. The due date for public comment will be August 31st, which is why there has to be this comment period. That's why they released what they did last week in order to meet the full comment period. But we would love it. And on our next town hall, we will at that point in time have delved into what the rest of the rules say. This was a minor piece that we found in the rules, so there's a lot more to digest and evaluate. So we will send a link out to them tomorrow, but we hope to discuss it again at our next town hall, and we hope that that folks will sign on to our comments when we get them ready and are ready to send them into CMS, and also that people send in their own comments.
But we thought this nugget of very positive information, particularly for people with ALS and other degenerative conditions, was important to get to you right away.
Thank you very much. We have a couple hands raised. One who's been up for quite a while. I want to give it a shot. And before we do that, I'll give my usual disclaimer. We may have some audio issues. If we do, we'll just immediately mute the person again, and hopefully they will type in their question. So now I'm going to try to go to Gus, whose hand's been up for a while. Gus, are you there?
Yes, I didn't have any questions, but I did enjoy the presentation. Thank you so very much.
Well, thank you very much.
You.
You know what? That's better than a question. All right, let's try. Juliet, did you have a question?
Hey, can
Hi.
you hear me okay?
Absolutely.
Yeah.
Okay. So is there a distinction between progress, improvement, and maximum potential? You have reached your maximum potential. These are words that we are given about my brother in his they are stopping his home health therapy with, and I will say, but he doesn't have to show improvement in order for you all to continue his physical therapy and occupational therapy. And then they'll throw words out to me about, oh, he's reached his maximum potential. That was today. So, and this has been going on for 3 days.
These are all, this is Judy, Julia. These are all
Yes, I can see you.
phrases we hear. Oh, yeah, right. I forget. Usually there's a slide over my face. These are all phrases we've heard all these years. And let me take the first two. It's no longer improving. That's clearly not a legal reason to discontinue Medicare's coverage. And that's been litigated and decided in the Jimmo case. What was the progress phrase? He's no longer progressing.
Not showing no sign of progress.
Okay, so
not showing progress.
That's essentially the same thing as not improving, and it's
That's what I thought.
not a legal reason. You do not have to show improvement. I mean, the materials that we've showed you today again reiterate that on slide 21. It says CMS says we reiterate that the agency can get the outlier payment for patients with higher resource use, that is for who need more care, and that the patient's condition does not need to improve for home health services to be covered by Medicare. So that should be very clear. It's not true. Now, with regard to reach his maximum potential, that might be, let me kind of parse that out a little bit. And there I would suggest that what we, being pragmatic, see if the doctor would write a new order saying that what we need is for the patient the therapy to be in place to maintain the function the individual, your brother, I think you said, has.
Yes.
And or to slow decline. And with that clarity about what the therapist is trying to accomplish, hopefully you will not get the same pushback from the home health agency. So I would try that because that's an equal path to coverage to maintain or slow deteroration.
Yeah, I've tried that too, but
and get an order to that effect.
I end up with the same result.
So I'd like to add to that as well, because it brings to mind an example of someone that Judy helped several years ago. And the key phrasing would be, is it safe and effective? That it needs to be done by a skilled person in order for something to be safe and effective. And even though someone could say something like they've reached their maximum potential, Judy had a client who literally had their arm broken because someone who was unskilled was trying to do some range of motion exercises to keep them from getting contractures. And so the whole thing about maintaining as much functioning as possible, and when somebody reaches the point where they can't anymore, they don't have the ability to maintain or to regain any function, it does have to do with just being able to have someone skilled who can help to stop pain from occurring or harm. So that's where the terms that Medicare uses about safe and effective really come into play in a big way.
Yeah, well, and there's some health agency on Sunday, the PT was there, and he handed my sister-in-law that Medicare, the notice of Medicare non-coverage, that form 10123 form, you know,
Yeah.
the one that they give you when you're discharged.
Yeah, and
So he handed her that, but he didn't put a date on it as the last date of service, but that was his last day. And he said, this isn't a discharge. I'm gonna put in for more visits. And I told her, I said, call Kepro right now and file an appeal. So Kepro registers it as an appeal, even though there wasn't a date on it. And they contacted the agency to get medical records. They didn't send the medical records in time. They sent them hours late. So as Kepro tells me, you won the appeal by default because the medical records were late. And I asked the agency, I said, so how are you going to handle this? You should have never handed that form to my sister-in-law. You should have started this process last week before the last date of therapy. And the director of nursing tells me that, well, we had to give her that because we didn't want you coming back at us saying that we didn't notify her that he might be discharged.
Juliet,
well,
interrupt and just so we can make the best use of our time. Did that notice use the language that your brother wasn't improving or no more progress or reach maximum potential? Is that in writing?
They put it on their forms, didn't reach maximum potential.
Yeah.
Or
so,
had
so if
you
wanted to get me a copy of that, I would bring it to the attention of CMS, because I know that the reason some of the language we've been able to show you today exists is because we have been bringing these stories to the attention of some people at CMS who are trying to do the right thing. And then the other thing I do recommend you do is get the doctor to make it clear that, be pragmatic. If he's reached his maximum potential, the goal now is to maintain what he has and or to slow decline. And so that sort of speaks back to the very point that they're making.
Right. And I would also remind everybody that under the conditions of participation, a person cannot be discharged from home health care now after January of this year without the express agreement of their treating doctor. So if some agency is trying to discharge someone, please, let us know, because that's not how something should happen without the express permission of the treating doctor.
Okay.
This doctor thinks that because the agency discharged them that they know best.
Yeah. Well, maybe there's another doctor who's involved with your brother's care that might say, in fact, he needs services to maintain or slow decline.
Yeah. We're going to him next week.
Good. Okay.
I don't want to take up any more of your time.
Thank you so
Thank
much.
you.
And
Somebody
thank you for
All right,
everything.
Okay.
Juliet, I believe you have my email. This is Matt.
Yes,
if
I
you
do.
want to get in touch with me after the
Yeah.
webinar ends, we can talk about getting a copy of that notice to Judy.
Yes, I'll do that.
Excellent.
Okay. All
Okay.
right.
Thank you.
We are a little over 4. We have some questions in the hopper still. Do you want to maybe tackle one more? Or
Yeah.
should
We're okay. And also, Matt, I just want to say for all of the folks that sent us in questions before the webinar, we will address everybody's questions and post those all up on our website.
All righty. Good note. Let's go with a concept question to end things. Is there some sort of a disconnect with agencies? Do we have to teach them? Why are they not aware of this? Why aren't they getting this info? That's from Libby.
Well, it's a good question. I think we both have something to say about that. I think there is some disconnect. I think part of what we did win this Jimmo settlement in the Jimmo versus Sebelius case, which addressed the very issues that Juliet was just asking us about her brother. You know, agencies should know that they can get Medicare coverage to provide necessary care for people who need it to maintain or slow decline, maintain function or slow decline. I think there's a variety of reasons that doesn't happen. One, I think that CMS did a poor education campaign, and we are pressuring them to do another education campaign. There is a lot of information on the CMS website, cms.gov. If you put in the search term Jimmo, you will find a lot of exactly what we're telling you right now to be true. And you can print that out so it'll have the CMS logo on it, not just the Center for Medicare Advocacy. There needs to be more education. There need to be some agencies that take these care cases, bill for them and get paid so that their colleaguing agencies hear that and know that they can be paid for this care. And take the chance on providing the kind of care that people need, and that should be the mission for these agencies to provide. And finally, we continue to do all we can to get the word out there. But if agencies don't get paid and CMS doesn't make sure that its contractors who make claim determinations don't grant coverage, then this is going to be an ongoing problem. So in the end of May, we went to Baltimore to meet with the leaders of CMS about that very question. And I have been persistent in trying to hear back. Just yesterday, wrote again to hear what are they going to do to get the word out better to both the home health agencies and to the Medicare contractors who make claim determinations.
Right. I think Judy covered it. I would just add that the policies that Medicare is continuing to develop, and I suspect we'll see in these proposed rules more of around quality measurements and investigations for fraud. There's a lot of disincentives to serve some populations of individuals, and so it's incumbent on us to again keep knocking on their door, keep pushing back, and advocating for what's right. You know, so CMS would have never come up with this example if, and we as a group, all of us have been questioning what is happening and why aren't people getting the care that they need. So that's really critical. And since I think that was the last question, Matt, I just also want to kind of reiterate what we think our next steps are on this. So please tell us about your success stories and your obstacles as you encounter them. Thank you, Jeff, so much for your story. Thank you, Jean. Thank you, everybody who is telling us about the fact that this is working, because it gives us more energy, frankly, from a selfish standpoint, but it also really helps one another. So if we can help to reach out, I will say one of the things in the next steps has to do with this outlier policy, which the thing that we didn't talk about today that we will certainly talk about in the proposed rules is that there's a cap on outliers for payment under Medicare of 2.5% of the total payments that Medicare makes for home health care. And so in order for, 2.5 might sound like a lot of money, which it is when you're talking about an $8 billion program. But from the standpoint of home health agencies that may be trying to push back because they feel that they have reached a cap, or they're saying that there's a cap, we need to get that cap increased. So that's one of the things that we're going to be looking at advocating for. If outliers is the answer to a lot of people who need significant amount of care, then let's make sure that the outlier payments that are available are significant and are appropriate enough to do so. So we'll be looking at that.
I just want to make a plug also. Like I asked Juliet, if you've gotten anything in writing that continues to use any of these legal standards for denial, improvement, not you reach your potential, not enough progress, do you be in touch with us, and if you can, get us a copy of that, and we will get that in turn on to those who should be fixing this at CMS.
Right. And we're a small but mighty group. We have very limited resources, so we need assistance across the country. So please reach out to Matt, reach out to me, Judy, and let us know if you're willing to do something like a survey home health agencies. We would provide you with the materials that we need. We know people with ALS and people who are helping people with ALS have so much on their plates already. But for anyone who can help us in this advocacy fight, we would appreciate it, because I think we're making some progress, and that's good. We want to make sure that we keep going along, and
yeah, we're nothing if not persistent.
Exactly.
Good. All right, thank you. And thanks to everybody who joined us today, and especially to all of you who stayed on with us as we went a little bit over time. Thank you to Judy and Kathy for some great information today. Special thanks to Jeff for sharing his story with us today. It really does give us some hope here. And of course, our thanks to Team Gleason. And one last plug, please everybody remember to go to honorgleason.com once you're done here and send a message to your representatives to support Steve's nomination for the Congressional Gold Medal. And please do join us Wednesday, August 8th at 3 p.m. for our final town hall. Once again, it'll be your show. Hopefully we'll have some more good news. Thank everyone again, and I will conclude our session at this time.
Thank you.
Thanks,
Have
Matt.
a good afternoon.